And RTA is part of differential diagnosis of a number of pediatric endocrine conditions. Unfortunately, it's a non-specific presentation. So often there may be confusion in terms of diagnosis. RTA, and why a pediatrician need to know about RTA is because RTA is common differential of a number of conditions, including polyuria, growth failure. Along with that, you can have problems in terms of nephrocalcinosis, there could be paralysis, so there could be a wide variety of presentations in RTA, and often there can be a confusion which can happen. So this was a 3-year-old boy with failure to thrive and hypokalemia, and the workup which was done in this phase was showed that there was a metabolic acidosis. And when we discussed about hypokalemia, we said that if you have hypokalemia and acidosis, your differentials are limited. Everybody who is hypokalemic is usually alkalotic. So if you have acidosis with hypokalemia, the differential becomes quite less. So further workup was done in this case, which showed a normal anion gap metabolic acidosis, which basically is in the sense of a scenario which suggests a possibility of a RTA. Subsequent workup was done which showed a urinary pH of 7.5. So if you have somebody who has got a metabolic acidosis, acidic blood and an alkaline urine, one would say that we have a problem in terms of acidification, and based upon that a diagnosis of distal RTA was considered. However, on evaluation, it was found that he also had a significant urinary loss of bicarbonate. So now we say that Fe bicarb, which is high, is suggestive more in terms of a scenario of a proximal RTA. So this issue of proximal versus distal RTA would cause a concern and confusion in this setting. So what could really have happened in this case? In this case, what we found that this child actually had a urinary tract infection. And when we'll discuss subsequently as to how do we interpret a urinary pH, we'll discuss in that scenario that UTI is something which can have a significant impact. So evaluation of RTA and classification is quite challenging, but needs to be done because different forms have different treatment and different implications on subsequent part, which we'll discuss later on. Second, again, a similar scenario was this 12-year-old girl who had significant multiple fractures, failure to thrive, polyuria and myopathy. There was hypokalemia which was there. Now, if you have hypokalemia and acidosis and rickets, I think the diagnosis of RTA is pretty clear. Now, if I were to be asked about this case who presents to you with fracture at a later age, this is most likely a case of distal RTA because that is a much more severe form and presents often late in that regards. Now, here again, there was a normal anion gap metabolic acidosis and a urinary anion gap was positive, which really excluded a gastrointestinal loss. We'll discuss about these subsequently in terms of evaluation. And there was hypokalemia and the urinary pH was high. So again, this was suggestive of a distal RTA. However, the workup showed amino acid urea. And this is often a confusion that if you have amino acid urea, you will think that this is more likely to be a Fanconi syndrome of a proximal dysfunction. So while the first case, we were misdiagnosing distal RTA because of urinary tract infection. This case, the confusion was whether this is really a proximal RTA. But here again, we need to remember that if you have secondary hyperparathyroidism because of any cause, which is long-standing, you may have a scenario of a Fanconi-like picture of glucose urea, amino acid urea. So again, the diagnosis of RTA, though there are algorithms there, may be sometimes challenging, which you need to be careful about in that regards. So all of you can go and have a look at our website, learning.growsociety.in, which has got multiple resources available for pediatric endocrinology, including e-learning resources on the YouTube, as well as our platform, which has got a lot of validated tools for practical assessment, courses, which are multiple, including fellowship and pediatric endocrinology courses. We do run a number of programs in terms of a lecture series, as well as grand rounds to cover different aspects. And our publications are there about pediatric endocrinology, advanced forms as well as basic forms are available. And our mobile application, which we'll try to see how it can help in terms of reaching the correct diagnosis in that regards. So when we talk about the acid bed regulation, we are basically talking about the excretion of proton and bicarbonate, which are there in that perspective. So kidneys play an important role in regulation of both excretion. The other organ which regulates the acid bed balance is the lung, which is predominantly talking about the carbon dioxide excretion. So proton, as we'll discuss in some detail later on, is essentially secreted in the urine. You will not be able to get the proton in the urine. You have to push it against a gradient. So it requires a lot of energy. This is done by the kidney. It's a complicated process. A lot of energy is required. So you will only be giving 1 millimole per kg. That will be there. Any proton which comes to the urinary tract lumen will go back again. So the main problem then is to really sequestrate it using ammonia so that ammonium excretion becomes significant. So it's actually ammonium and not proton, which is a marker of urinary acidification. Now the second agent is bicarbonate, which is much more easier in terms to filter. So essentially a lot of bicarbonate is filtered every day. So for an adult, we are talking about 4,000 millimoles per day, approximately 70 millimoles per kg per day. So it's like a huge amount of bicarbonate which is filtered, but most of it is reabsorbed. So only 1% will be excreted. So now if you think about it, you are acidifying by two mechanisms. One is that you are basically pushing off your amount of proton so that you don't have too much acid in the blood. And second, you are reabsorbing the bicarbonate. Now, if you have a problem in the acidification of urine or in bicarbonate reabsorption, you will have acidosis. Now, which of these will be more difficult to treat? Not in severity in terms of when you're replacing, what will be the most difficult to achieve a good bicarbonate level? You will need much more amount of bicarbonate. Of course, in terms of severity, and I'll talk about that if you have a filtering defect, a reabsorption defect, if your bicarbonate goes below a particular level, you will not be excreting it. So therefore, it will be a self-limiting condition. So proximal RTA, as we'll discuss, is a self-limiting condition. However, as soon as you bring the level to a higher level, you will have this bicarbonate urea happening. So it's difficult to treat, yet it's not very severe. Distal RTA is more severe, but it is easier to treat. The amount of bicarbonate required is much less in that perspective. So 90% absorption happens in the proximal tubule. So bicarbonate, as with many other things like sodium, potassium, glucose, this is all freely filtered via the glomeruli, and all of which will go into your proximal tubule. Now, proximal tubule is the major source of reabsorption of all these contents. And this reabsorption basically will result in absorption of more than 99% of your bicarbonate will be absorbed using the carbonic anhydrase, which is there, and the sodium bicarbonate transporter. So it's like a co-transporter transport. It's not a very, very active transport except for the carbonic anhydrase. Now, 90% of bicarbonate is absorbed here, and around 10% will be absorbed in the distal tubule. Along with bicarbonate, the proximal tubule is a major site of absorption of water, glucose, phosphorus, amino acids. So a lot of things are also absorbed here. So you will have a phosphorus, amino acid absorption. So if you have a generalized defect in the proximal tubule, you will have glucose urea, phosphate urea, amino acid urea, besides having a metabolic acidosis. However, if you have a problem specifically in the sodium bicarbonate transporter or the carbonic anhydrase, you will have an isolated proximal RTA, which we'll discuss a bit later, which Dhani will talk about in that regards. And glucose is also lost here. So glucose urea is often a easily identifiable marker of proximal RTA and is often missed. So whenever you look at urinary routine examination of a child with failure to thrive, always look for glucose, because we will see often miss. I've seen many times it was there, but it was missed. This glucose urea was missed, and then RTA was not diagnosed in this scenario. Now, as I said, 10% of bicarbonate is largely absorbed, 9 to 10% at the level of distal tubule, and only 1% of it is really excreted. Now, proton handling is a more difficult scenario because proton is actually an acid. So when you are putting acid inside, you will need to be careful. It's not an easy process. You need an active transport there. So you need two major transporters, the potassium ATPase and the proton ATPase. So it's being transported in lieu of potassium or directly pushed here. And this provides a huge gradient. So actually there is a 250 times higher level of concentration of proton, which you can achieve in the lumen with the help of these active transporters. So they play a big role there in that regards. Now, the problem with proton is that if you keep proton here, it can easily go back because there is a big gradient. So now you have created a gradient. If there is a gradient, it will go back into the circulation, and again you will not be able to carry it forward in the urine. So what body does in this scenario is to produce ammonia, and this renal ammonia reacts with the proton to produce ammonium ion NH4 plus, which basically is the one which takes the proton along with that. So any condition in which your ammonia production is defective, you will not be able to acidify, and this will result in decreased proton loss, and you will have an issue in terms of proton excretion. Now, which of the electrolyte inhibits ammonia production? And what will be its implication? So if your potassium is high, yeah. So when your potassium is high, and we know that proton and potassium are antagonistic. When you talk about cellular exchange, if your potassium becomes more, it goes into the cell, proton comes out. Similarly, if you want to excrete potassium, it has to compete with proton. So what potassium does very opportunistically is that it is really inhibiting ammonia. So then proton cannot go out, and then potassium will go out. So anybody who has hyperkalemia will have metabolic acidosis. Anybody who has metabolic acidosis should have hyperkalemia, and that is the basis of quote-unquote type 4 RTA, as we'll discuss subsequently in that regards. So then you will have excretion of around 1 millimoles per kg per day, which means that once you have corrected the initial deficit in terms of the acid level, you can then give only 1 to 2 millimoles per liter per day, kg per day of bicarbonate, and that should be sufficient in distal RTA. So as I said, distal RTA is more severe, easy to treat. Proximal RTA is less severe, difficult to treat in that regards. Potassium, as I said, is very, very closely linked to this whole process, and potassium abnormalities may be the first sign of identifying these disorders. So potassium basically again is mostly absorbed at the level of the proximal tubule. And whatever potassium that appears in the urine is because of the issues in the collecting duct. So you have this epithelial sodium chloride channel, which basically takes sodium outside the lumen. And once you take sodium outside, you will also take chloride along with that. Now, the chloride lags, the speed of chloride absorption is lower as compared to sodium. So therefore, you will have a negative environment here. So now you have an electrochemical gradient for potassium. So potassium can now enter into the lumen. So effectively, what you're doing here is that you are exchanging sodium for potassium. So any condition where your sodium delivery in the distal tubule is more, you will lose potassium and you will have hypokalemia. So if you have, let's say, somebody who has RTA, you give them soda bicarbonate, what will happen?
On bicarbonate, we are delivering more sodium to the distal tubule, and it worsens the hypokalemia.
So if you are giving sodium here, you will have exchange here. However, if acidosis, if you have intracellular acidosis, that is also going to cause potassium loss. So in distal RTA, if you correct that intracellular acidosis, this potassium may improve over time. Now, as discussed, this proton will be excreted along with ammonium, and this proton and potassium have an antagonism, so to speak, in terms of this scenario. Hyperkalemia, as I discussed, inhibits ammonia production, therefore reducing proton excretion, causing mild metabolic acidosis in that regards and in that scenario which happens in that regards. So anybody who has acidosis, what all should they do? So of course, if you have acidosis, you would want that you are going to have a good bicarbonate absorption. So in the presence of metabolic acidosis, your Fe bicarb should be less than 5%. The second scenario is that your ammonium production should be more, which means that when you talk about urinary anion gap, you will have a lot of ammonia in the urine. So the urinary osmolar gap and the urinary anion gap, which I'll talk a bit later, should also be positive. So that is a normal response in that scenario. And then, of course, you should have a acidic blood and an acidic urine. So the normal response is to have acidic urine. You will expect potassium loss to happen in that regards. Now, in this perspective, if we talk about the pathophysiology of RTA, you can broadly have problems either in the proximal tubule, or in the distal tubule. As discussed, proximal tubule is a milder disorder. As soon as your bicarb becomes below 15 or 13, you will not be filtering bicarbonate, and therefore there would hardly be any further acidosis which will be there in that regards, and you will have an acidic urine. There will be no renal calcification. The reason for that is that you have got specifically citrate which is also being lost, and because of the loss of citrate you will have preventive measure which will happen in that regards. Now, as far as distal RTA is concerned, the problem predominantly is in the distal tubule in terms of acidification. This is a more severe disease with alkaline urine and calcifications which are more common in that regards. Then you can have a problem of type 4 RTA, which is not really a renal problem. It's more of a aldosterone problem in either aldosterone production or action, and that can cause hyperkalemia, metabolic acidosis to a milder extent, which is there in that regards. So this is the overall pathophysiology. As far as the RTA is concerned, we will now move forward more in terms of the etiological aspect.
So we have this 2-year, 9-month-old girl who presented with the failure to thrive in polyuria, and you can see in the picture there is a rachitic changes, widening of the wrist. So, and the blood gas was done, which was acidic, and the anion gap was 12. So, is this case a case of RTA, or what should be the next step to be done in this case?
You can write on the chat option.
Any answers?
So there are some answers coming in the Q&A.
Q&A one can see. RTA, it's not RTA. What should be the next test? It's RTA is not the diagnosis. So what should be done?
Considering RTA, what
but
should be
the next step?
You have acidosis which is there and a normal anion gap. So you should exclude causes of acidosis and other causes. Any answer?
Creatinine, definitely it's the correct answer. We should go for the serum creatinine and rule out the glomerular cause of the acidosis. Bifinum. Okay. So this was CKD and it was falsely diagnosed as RTA. Now coming to the second question, we have this 3-year-old boy who came to us with failure to thrive, diarrhea and acidotic breathing. When the blood gas was done, it was acidic in nature, and sodium was 131, potassium was low, and chloride were 110. So what should be the next step to be done in this case?
You have hypokalemia with metabolic acidosis. So any answers? I think we have very few differentials of hypokalemia and
acidosis.
One, of course, is RTA, and we're discussing on RTA. The other ones are.
That's the next steps of what should be done.
So, what are the other differentials?
Sir, before this is hypokalemia with the metabolic acidosis. First, we have to see what is the anion gap here. So, definitely, I think nobody has given the answer. So, it's the anion gap. So after anion gap is normal, now the differentials are very limited with the
urinary anion gap.
Yeah, definitely the next step was to get the urinary anion gap, and which was 5. So most likely diagnosis in this case would be.
You have a urinary anion gap which is -5 or +5?
-5.
So what do you think? Anybody is answering?
So I think nobody has.
AGE, Dr. Parameter.
Yeah, definitely it's the GI loss, bicarbonate diarrhea. Now coming to the next question, we have this 5-year-old child with rickets. As you can see, there is a genovulgum with widening of wrist here, and the blood gas shows there is a the acidosis is present, and the urine pH is 5.8, and the anion gap is normal. So this patient was labeled as distal RTA and was sent to us. So what is the next step to be done in this case? I think we have already discussed it.
RTA, that is a big question. There is definitely a lot of rickets which is there. What
and then gap. Sir, definitely, she presented with short stature.
She was short as well. So before you label RTA, what will you think of? Anybody has answered?
And this question has already been discussed here.
So before you label somebody as RTA,
RTA.
the key question here is that
What is the
what is the
vitamin D
level?
ALP? What is the vitamin D level? Some
And the metabolic acidosis is mild.
mild.
So as
Yes, sir.
discussed, it's unlikely to be RTA. So renal dysfunction, we have to rule out, of course, a vitamin D deficiency and secondary hyperparathyroidism.
So this was the case of vitamin D deficiency with secondary hyperparathyroidism. Okay. So coming to next question, we have this 6-year-old boy who presented with polyuria and polydipsia, and they came with their ultrasound, which showed nephrocalcinosis, as you can see in the picture, and the creatinine level was normal. He has low sodium, which was 125, hypokalemia, and the calcium was 8.8. So what should be the next step to be done in this case? Is it RTA or something else, or what should be done here?
Nephrocalcinosis with polyuria, you don't have any bony abnormality.
No, sir. Just the patient came with a X-ray and
So one important thing that if you have low calcium and you have nephrocalcinosis, what does it mean? Serum calcium is low.
Serum calcium is low.
But you have nephrocalcinosis.
It means the calcium is being excreted in the urine and lungs.
It means on one hand, if you have high calcium in the blood, high in the urine, which means this hypercalcemia. This means the cause of hypocalcemia is urinary loss.
Yes.
You are losing in the urine, which becomes.
So definitely this is tubulopathy, but
blood gas.
yeah, definitely.
So who did blood gas?
Dr. Parag.
Yeah, blood gas should be done because tubulopathy, it could be RTA or it could be another cause. So if the blood gas shows it was alkaline and the bicarbonate was 26, so what could be the most likely diagnosis in this case? Any answers? Yeah, definitely it is the Bartter syndrome. Okay. So we have a next case. We have a 3-year-old boy who presented with failure to thrive and polyuria and polydipsia. There was a acidosis and urine pH was 7.5 and there was a hypokalemia as well. He was diagnosed as a distal RTA and patient. This was yeah. This question is all.
So clearly you have a child whom you label as RTA. Urine pH should be looked into only when you have a normal urine microscopy and the urinary sodium is normal. If you have dehydration and if you have a UTI,
yeah.
Honestly, a diagnosis in terms of the urine pH. That's an important question.
So coming to the next question, this is a numerical question. We have this 8-year-old boy who presented with some blood reports where the sodium was 135, potassium was 3.2 and chloride were 114. Blood gas shows of the pH 7.1, bicarbonate 12 and base X is minus 18 and urine sodium of 40, this urine potassium of 4 and chloride of 42. So now you have to calculate what is the anion gap in this case. Blood. Definitely, it's the anion gap is 9. Sodium minus chloride plus bicarbonate is the formula. The next question is, what is the urinary anion gap in this situation?
Yeah.
It's a
2.
yes.
Somebody asked it.
Just negative.
Negative. Okay, it's not. It's positive.
Generally, it be much more positive. So it's not a very confusing picture. If it's actually a GI loss, it will be significant. Minus 20,
yeah.
something like that. So this is classically a case of heart.
And this is the just general question of pediatrics. Calculate the expected PCO2 level in this case. We know the formula and
what should be the CO2? What is the ratio of bicarbonate and CO2 in terms of compensating response? Other one.
Yes. Is 1.5
1.8 plus minus 2. So
in this case, you expect it to be 20.
it's 26. Okay. So the last case, we have this 10-year-old male child who presented with jaundice, growth failure, and abdominal pain. Definitely low cellular plasminogen, and the 24-hour urinary copper challenge was more than 500 after the penicillin challenge. And he was diagnosed as the Wilson disease. Okay. Now the mother complains he has a frequent bedwetting. So what is the cause of polyuria in this case? I think it's very clear here.
You've already discussed that you have
Ha.
these tyrosinemia, cystinosis. Which form of RTA do they cause? Generally proximal. Any answer?
Any answers? No, no one has given the answer. Definitely, it's the proximal RTA due to the Wilson's disease. We have this 17-year-old female who presented with weakness of all 4 limbs. There was a history of episode of periodic paralysis, but there was no history of any drug or polyuria. And on the asking further, she has given us that she has a complaint of dry and she is using this artificial tears very frequent. She has a dry mouth since 2 years.
So we should ask the diagnosis. Somebody who presents you with periodic paralysis and dry mouth. I think diagnosis is very simple, very clear. So of course, we're talking about RTA.
Yeah, definitely this is a distal RTA. Yeah, but what is the cause of this distal RTA? Jogging? Yeah, definitely it's jogging, it's not SLE, sorry. And what treatment would you give in this condition? No, sir, definitely there's a treatment of distal RTA, that's bicarbonate, the potassium citrate. So this is a rapid fire. This is a one-liner one, and you have to respond very quickly here. What protects the renal calcification in proximal RTA?
Why do patients with proximal RTA?
Citrate. Okay, bifenamab has an citraturia. Definitely it's citraturia. The hypokalemia worsens with bicarbonate treatment in distal RTA or the proximal. This is the simplest question, I think. Proximal RTA, definitely it's the proximal RTA. Next question. For the proximal RTA, what are the 2 better tests than the urinary pH?
To diagnose proximal RTA, which test you will prefer more?
Who has answered? Bifenamab is again fractional excretion of bicarbonate only after the correction of acidosis and the urinary to blood CO2 difference of more than 20 H. Next question, name 2 medications that induce distal renal tubular acidosis. Distal. Yes, sir. Distal. It's the proximal. Yeah, amphotericin B in the FS point. The last question, urinary anion cap is a marker of. That is discussed it many times here.
Surrogate marker of production of what? Somebody asked.